Thank you so much for this opportunity. So my job is to essentially review surgical protocols. Unfortunately or unfortunately, it's generally a bad idea to try to teach surgery to surgeons because that's like reinventing the wheel. Most of the questions I'll try to touch upon are those questions which are essentially non-surgical, but yet the surgeons have to often answer them in their own practice. I'll just go over them quickly and I'll try to not overlap with the previous or the next presentation. So essentially, when you try to understand surgical practice in the COVID times, it's useful to divide the surgical workload in 5 parts: pre-op, immediate peri-op, pre-op, intra-op, post-op, and post-discharge. Some of this will be touched by me, some of them are already covered by Dr. Ashish, and some of them will be covered by Dr. Gaurav. In general, what we are interested in as surgeons is reassessment of the primary disease. Mind you, quite a few of these patients which are coming to us now have already been worked up earlier, a few months back. Some treatment has already been given. Usually in oncology, some other form of non-surgical treatment has been given. So a reassessment is very important. In oncology, reassessment would essentially mean that you restage the tumor with imagings depending on the tumor, whether it's PET-AVID tumor, it's a PET scan, various tumor markers depending on the specialty you are in, and very importantly, constitute tumor boards to make individualized decisions, because often these patients have undergone treatments which are non-conventional in the past few months. So individualized decisions would be better made by multiple heads coming together rather than one person. The next question surgeons often have to answer in their practice is, how do we then screen for COVID before we operate these patients? So the general protocol I've just put out here, and it's important to understand that these have been evolving over the last few months. And so this is just a kind of a screenshot of what we are doing at present. And it may change in the future as more information comes. So the first thing we do in practice is to do a symptom screening. And of course, patients who have symptoms don't come to elective surgery at all. They need to be assessed elsewhere. Second thing is about the quarantining part in the preoperative period. The incubation period of the virus is up to 14 days, 2 weeks. That's generally understood. So CDC and the Royal College both have recommended that before the patient gets admitted, they should be home isolated for 14 days. This is whether it's practicable or not in our setup is something we'll come to a little later. The third thing is that the patient should have COVID testing by RT-PCR. Unfortunately, now we understand very clearly that about up to 30% patients will have a false negative test if done once. And therefore, most guidelines and articles seem to recommend that at least 2 RT-PCR should be done to reduce but not eliminate the false negative rates of RT-PCR. Somewhere in June, Director SGPG had constituted a committee of senior surgeons to tell us exactly what we should be doing when we resumed surgical practice at that point in time. This is what we were told to do at that point in time. This is probably holding true even now. May need modification later. So what we had planned to do at that point in time was to get one negative RT-PCR from SGPG, admit to a holding area which is restricted access to the healthcare workers and only essential staff, and then a second RT-PCR after about 5 days, and then surgery within 72 hours of the last RT-PCR test. This is definitely not a foolproof way of working, as we have found out in the last few months, but this is what is holding us as of now till we modify it. Now, this is a subset of patients which we surgeons will get to see more and more often in the next few months. So I suggest we pay more attention to this aspect. Part of the aspect was covered by Ashish already, that is physiological reserve of these recovered patients. I'll be covering a little bit of the infectivity and testing of the recovered patients when they come to us for elective surgery. Now, when we talk about infectivity of the recovered patient, we should understand that there are two questions you need to answer. When is the patient rendered non-infective after the initial positive test? And then what if the patient has a reinfection before you operate that patient? A good resource is the CDC website for this particular purpose. Remember that COVID recovered patients can continue to shed virus particles for up to 3 months. And this is common knowledge now. It wasn't so a few months back. But there is a difference you must understand between detecting virus RNA, which is fragments of the RNA, versus detecting viable, in technical terms, replication competent virus. Now, what we are really interested in is the viable virus, because that is what determines the infectivity. So not just an RT-PCR positive patient in a COVID recovered patient. How do we take this forward? Most patients do not shed viable virus beyond 10 days. This applies almost universally to mild to moderate COVID infection. And hence the CDC website in COVID recovery had said that at least 10 days of home isolation is required for mild to moderate infection. And our government of India had added another 1 week to that, and that's what we've been following for our healthcare workers over this period. Yeah. However, in severe COVID infection, you can have viable virus shedding, and there are case reports of this up to 20 days, but not beyond in most instances. So then what are the chances of reinfection? So patient has been rendered COVID negative. Now what if he gets reinfection before surgery? Do we need to retest in a COVID recovered patient? Well, the bottom line seems to be as of today that most of these patients are protected against reinfection up to 3 months because of immune system getting enhanced or whatever. Although of recent past, rare cases of reinfection case reports have been documented. We are still in the process of evolution for this, but there is a kind of implication for surgery, and that is that once a patient comes to us in COVID recovery, do we really need to test? This is a question we have no clear answers to, but this is the common state of knowledge as of today in this particular scenario, and more of these patients will come to us for surgery in the next few months. What changes have been incorporated? Well, there are questions we need to answer. Some of these will be answered by Dr. Gaurav. Some of these questions I will take quickly. We need a separate OT. I think Ashish made it very clear, and what air circulation requirements are required, he's also touched upon that aspect. What I want to emphasize is that our usual practice and a very bad practices of sharing instruments across operation theaters should be avoided, because this is a sure short way of transmitting infection from one OT to the another. And minimum required equipment should be kept in the OT, and this needs to be emphasized with no exchange during surgery. Manpower requirement, I think, is already touched upon, but what we often forget is that we need a lot of time between cases. And what is recommended is at least 1 hour is required for complete air exchange, followed by disinfection of the OT. So that needs to be factored in when you make lists for elective theaters. And a very important aspect of the whole thing is about the OT attendant in the corridor. This again is a practice we don't follow very often. Our OT staff runs to the OT pharmacy to get equipment, and this should be condemned. Personal protective equipment, we have been using this for the last 6 months. All of us are aware of what it means. The problem really is that we understand that the PP, the way we understand PP today is this, either one on the right or one on the left. Actually, personal protective equipment means anything which protects you in a given scenario. So it also depends on the scenario you're working in. And so hence a question which often comes across is how much personal protection do we need to use during surgery? So to generally understand this, we need to put it into two streams. One is a COVID positive suspect, where there is no doubt that we need to use full PP. The second is a COVID negative, to ask RT-PCR negative. There we ask a question often, this is discussed, do we really need to use a lot of PP in those patients? Well, till about a few months back, initial part of the pandemic guidelines, even CDC told us that in a COVID negative, proven COVID negative patient, we don't need to use any specific precautions or regular precautions. This is still there in the publications. However, over the last few months, this has changed, and we've realized that our testing for COVID is not all that accurate, and so there are a lot of false negatives. So as of today, the guidelines have been modified in various publications and say that similar precautions to COVID positive patients should be used in COVID negative also. Surgical smoke has been the bugbear of surgeons. What essentially it means is that when you use energy sources during surgery, it generates smoke and aerosolization of various things. It has been likened to passive smoking in cigarette smoke. And most of the emphasis over the last few decades have been over chemicals, carcinogens. And with the coming of COVID-19, we have started emphasizing the aerosolization of viable pathogens. Yes, viable pathogens have been documented in the surgical smoke. Fortunately, so far, nobody has documented transmission to the surgical team. So it seems that we are all right, but we still need to take precautions. Lab versus open, the fear of laparoscopic surgery was that we are aerosolizing the tissue fluids in a closed compartment, and hence a high concentration of virus will be there. And when this leaks from the ports and instrument exchanges, it's going to affect the surgical team. So initial part of the pandemic, laparoscopic surgery was condemned, and it was said that open surgery is the way to go in the initial part of this year. However, over the last few months, we have learned that with sufficient safeguards put into place, quite a few of them, laparoscopic surgery has proved to be no more risky than open surgery for the surgical team. So as of today, we can go ahead, provided quite a few of the safeguards are put into place. And some of the safeguards include smoke evacuators, which means essentially that the aerosolized carcinogens and the pathogens are directed through a filter, which is usually a ALPA filter, in a controlled way, and hence does not go into the OT atmosphere. Accessories for these are available in laparoscopic and open surgery. We have one in our hospital right now, which is actually come with the robot. However, these are expensive stuffs, and even the use is expensive. This is probably the most expensive one in the market, and I can tell you that we spend about 15 to 20,000 per case in only disposables for this in use. However, there are others, the prominent ones being the Ethicon Johnsons and the Medtronic smoke evacuators, which are running their bids in our country. The list is available on the SAGE's website of Medical Device Repository, and they have their own disposable, so added cost to surgery. This is my last
Rajneesh, 2
slide,
more
and this.
minutes, please.
So I'm
2 more
finishing, sir.
minutes.
This is my last slide. Yeah. So this is essentially pertaining to the post-op recovery. Now, all of us have been through recovery protocols, which pertains to our specialty, our disease, our wards, and often we try to protocolize that. Why I'm projecting this is that it's important to understand those protocols may not work perfectly in the COVID times. This is a publication from Italy, which essentially tried to reanalyze their ERAS protocols and try to figure out which components of the protocol need modification and which components can be implemented as is. So obviously a generalization cannot be made. We have to make specific guidelines for each specialty and disease. But you must understand that for each recovery, in each specialty, you need to modify protocols so that they're implementable and give you good results, rather than carry on the same protocols of post-op recovery as in the earlier non-COVID times. Thank you so much. We'll take questions and answers later on.